Good day. I am Ivan Benjamin M. Bagas from General Surgery. I will be discussing the diagnostic modalities employed for urology. Urinalysis. It is the most important and useful urologic test. Reasons for inadequate urinalysis are improper collection, failure to examine the specimen immediately, incomplete examination, inexperience of the examiner, inadequate appreciation of the significance of the findings. Timing of urine collection. Best to examine urine that has been properly obtained in the office or laboratory. First morning voided specimens are helpful for qualitative routine testing in patients with renal disease due to diabetes or hypertension, or in identifying benign orthostatic proteinuria. Urine specimens that are obtained immediately after the patient has eaten or has been left standing for a few hours becomes alkaline, thus may contain lyse red cells, disintegrated cast, or rapidly multiplying bacteria. Freshly voided specimen obtained a few hours after a patient has eaten and examined 1 hour of voiding is the most reliable. Method of urine collection. Specimen should be obtained before a genital or rectal examination in order to prevent contamination from the introitus or express prostatic secretions. Urine obtained from the condom or chronic catheter or intestinal conduit drainage is not a proper specimen for urinalysis. In adults, simple collect a clean voided midstream urine sample. In men, the foreskin should be retracted prior to voiding. The glans and meatus in men or perineum with spreading of labia can be cleansed with a castile soap toilet. The patient then passes the first part of the stream, 15 to 30 ml without collection, and collects the next or midstream portion, approximately 50 to 100 ml, in a sterile specimen container which is immediately capped. In children, urine for analysis other than bacterial cultures can be obtained from males or females by covering the cleansed urethral meatus with a plastic bag. Urine specimen for culture may require catheterization or suprapubic needle aspiration in children too young to void spontaneously. Macroscopic examination. We have to look at the color and appearance. Some drugs can change the color of our urine. These are the examples. pH level. Patients with uric acid stones rarely have urinary pH greater than 6.5, as uric acid is soluble to alkaline urine. Patients with calcium stones, nephrocalcinosis, or both may have renal tubular acidosis and will be unable to acidify urine pH less than 6. Urinary tract infection caused by urea splitting organisms, the urinary pH tends to be greater than 7. Glucose. The glucose oxidase peroxidase tests used in dip strips are quite accurate and specific for urinary glucose. False positive results may be obtained when patients have ingested large dose of aspirin, ascorbic acid, or cephalosporin. Hemoglobin. The dip strips test for hemoglobin is not specific for erythrocytes and should be used only for screening for hematuria, with microscopic analysis of the urinary sediments used for confirmation. If patient has a positive dipstick but a negative microscopic evaluation, the microscopic exam should be repeated 3 times for verification. Bacteria and leukocytes. Test strips to determine the number of bacteria or leukocytes are predictors for bacteriuria are specific but not particularly sensitive as microscopic evaluation. Microscopic examination. Early morning urine is the best specimen if it can be examined within a few minutes of collection. Centrifuge a 10 ml specimen for 5 minutes, decant the supernatant, resuspend the sediment in the remaining 1 ml of urine by tapping the tube gently against countertop. Place 1 drop of the mixture on a microscope slide, cover with cover slip, and examine first under low power lens and then high power lens. You will be interpreting the results. The bacteria, leukocytes, erythrocytes, epithelial cells, casts, and other findings. Bacterial cultures. The presumptive diagnosis of bacterial infection based on microscopic examination of the urinary sediments should be confirmed by culture. Cultures can be used to estimate the number of bacteria in the urine, to identify the exact organism present, to assess which drug will be effective in treating the infection. Number of bacteria present in urine is influenced by hydration status, antimicrobial drugs. Ultrasound. Commonly used for the evaluation of the kidney, urinary bladder, prostate, testes, and penis. It is also useful in assessing the renal size and growth. Triaging patients with renal failure, samples showing small echogenic kidney suggests of a renal parenchymal disease. Ultrasound provides effective method distinguishing benign cortical cysts from potentially malignant solid renal lesions. Most common renal lesions are simple cortical cysts. Doppler sonography is useful for the evaluation of the renal vessels, vascularity of the renal masses, or complications following renal transplant. It detects the renal vein thrombosis, renal artery stenosis, and urethral obstruction prior to the development of hydronephrosis, arteriovenous fistula, and pseudoaneurysm. Bladder sonography, assessment of the bladder volume, wall thickness, and detection of bladder calculi and tumors. Suprapubic transabdominal is most commonly used. Transurethral approach during cystoscopy is recommended for tumor detection and staging. In testis and scrotum, perform with a high-frequency transducer for excellent spatial resolution. Additional of color and spectral Doppler sonography provides simultaneous display of morphology and blood flow. It is highly accurate in differentiating intratesticular from the extratesticular disease and in the detection of intratesticular pathology. So what are the advantages and disadvantages in ultrasound? Advantages are, it's very easy to use, high patient tolerance, non-invasiveness, lack of ionizing radiation, low relative cost, wide availability. On the disadvantage side, it is low signal to noise level, tissue non-specificity, limited view, dependence on the operator's skill and the patient habitus. Test of kidney function. Blood and urine tests shows how well the kidneys are doing their jobs and how quickly body wastes are being removed. Urine tests can also detect whether the kidneys are leaking abnormal amounts of protein because it is a sign of a kidney disease. Serum creatinine. Creatinine is a waste product that comes from the normal wear and tear on muscles of the body. Creatinine levels in the blood can vary depending on age, race, and body size. A creatinine level of greater than 1.2 for women and greater than 1.4 for men may be an early sign that the kidneys are not properly working. As kidney disease progresses, the level of the creatinine in the blood rises. Glomerular filtration rate. This test is a measure of how well the kidneys are removing the waste and excess fluid from the blood. It is calculated from the serum creatinine level using age and gender, with the adjustment for those of African American descent. The normal GFR can vary according to age. As older you get, it can decrease. The normal value of GFR is 90 or above. A GFR of below 60 is a sign that the kidneys are not working properly. GFR decreases below 15, one is at high risk for needing treatment for kidney failure, such as dialysis or a kidney transplant. Blood urea nitrogen. Urea nitrogen comes from the breakdown of protein in the food that we eat. A normal BUN level is between 7 and 20. As kidney function decreases, the BUN level rises. Radiography plain and with contrast. A radiopaque contrast medium is frequently employed to enhance a soft tissue contrast. Basic types of uroradiologic studies: plain kidney urinary bladder films, intravenous urograms, cystourethograms, angiograms. For plain kidney urinary bladder films, it is the simplest urologic examination. It outlines the kidney's size, number, shape, and position. The average kidney size in adults measures 12 to 14 cm long. Intravenous urograms, also known as excretory urography or intravenous pyelography. Cystourethograms, angiograms. In CT scanning, a thin collimated beam of X-rays is passed through the patient and captured by an array of solid-state or gas detectors. The interconnected X-ray source and detector system are rapidly rotated in the gantry around the recumbent patient. Computers integrate the collected X-ray transmission data to reconstruct a cross-sectional image. Most commonly used in the evaluation of acute flank pain, hematuria, and renal infection or trauma, and in the characterization and staging of renal neoplasm. CT evaluation of renal anatomy and pathology generally requires intravenous injection of iodide contrast media. Non-contrast scans are needed. However, when renal or perirenal calcification, hemorrhage, or urine extravasation is suspected, since scans can be obtained after administration of contrast media, may mask these abnormalities. So per and post-contrast scans are required to determine whether the mass is solid or cystic. Contrast medium is usually administered as a rapid intravenous bolus using bolus injection and multiphasic multi-detector CT. Renal arterial opacification is followed immediately by enhancement of the cortex. Clinical application. Ureters is predominantly for tumor staging and evaluation of the cause and level of obstruction. Urinary bladder, primarily for staging bladder tumors and diagnosing bladder rupture following trauma or post-operative setting. Prostate is used for detection of lymphadenopathy, for gross extraprostatic tumor extension, and to delineate prostatic abscesses. Used for detection of the abdominal location of suspected undescended testis or staging of testicular tumor in the search for nodal and distant metastasis. CT scan. What are the advantages and disadvantages? The advantages are wide field of view, the ability to detect subtle differences in the X-ray attenuation properties of various tissues, good spatial resolution, anatomically cross-sectional images, relative operator independence, reformatted helical image in different planes and 3 dimensions. Disadvantages: restriction to the transaxial plane for direct imaging, tissue non-specificity, low soft tissue contrast resolution, need contrast media, both oral and intravenous, radiation exposure. MRI is based on the nuclear properties of the hydrogen atoms in the body. Clinical applications. It is used for demonstration of congenital anomalies, diagnosis of renal vein thrombosis, and diagnosis and staging of renal cell carcinoma. Magnetic resonance angiography is used in evaluating renal transplant vessels, renal vein tumors or thrombosis, and renal artery stenosis. The use of contrast media in MRI of the kidney has broadened clinical applications. Using bolus injection of gadolinium and APID sequence, both anatomy and function of the kidney can be assessed. Used primarily to stage urinary bladder tumors and to differentiate between benign bladder wall hypertrophy and infiltrating malignant neoplasms. In prostates, it is primarily used for staging of prostate cancer. MR urography utilizes the sensitivity of the MR imaging to demonstrate fluid, producing urogram pictures without the need for contrast media. It is used for detection of urethrohydronephrosis. Advantages and disadvantages of MRI. Advantages are direct imaging in any plane desired, although transverse, sagittal, and coronal are the most standard. Choice of large or small field of view, excellent soft tissue contrast, imaging without exposure to ionizing radiation, less operator dependence, image blood vessels and urinary tract without contrast material. For the disadvantages, it is relatively slow. Result image clarity is often inferior compared with CT scan. Absent contraindication: intracranial aneurysm clips, intra-abdominal metal fragments, any electrically, magnetically, or mechanically activated implants like pacemaker, biostimulators, neurostimulators, cochlear implants, and hearing aids. Relative contraindication is pregnancy. Thank you.